we structure the course with Rob coming in. Rob Neighbor usually teaches this in like a 2-day like format. I think we're going to have to reevaluate that a little bit with the whole COVID thing going on. We may end up doing it on Zoom, or I don't know, maybe one day Zoom and another day lab or something like that. We'll see how it goes. But this is kind of an introduction to that stuff that kind of goes over what he's going to take on to the next level. So just kind of a good thing to kind of get some exposure to. I think the biggest thing you got to take away from that is that, I think doing this for 20 something years, the more you know, the less you really know. And I think kind of talking to Paul Christensen, who's the owner of OPTM that just kind of closed up over in Los Gatos and Willow Glen, talking with him a little bit is, he's been doing this for 40 years, like 40 plus years. And, there's funny things that, you might learn from him just talking to him. And that I've learned working for 20 something years, and then you hear him say it and you go, oh my gosh, this is something I've just learned, but he's already learned it in his 40 years. And so it's kind of understandable when people have only been practicing 2 months or 2 years, the level of things that they're exposed to is just not as much, and I think we kind of chalk up a lot to experience. But I think there is a lot of things that people can learn from them, and then we'll kind of go into what they're able to take from that experience as well. I think a lot of times people, when they get out of school, they want something that's either black or white, and it's really, concrete. They want to know the answer. I want to be able to figure out what's wrong with this particular patient. But what you end up finding is there's a lot more shades of gray. There's something in the middle. The other thing too is really the idea of the clinical reasoning is it just gives you a thought process to kind of follow through. So it's kind of like, I wouldn't say as hard of a protocol, but it's something that just gives you a systematic way of thinking through different things. So, one of the things I used to always kind of think of, the font's a little screwed up there, the indenting, is one of my professors, Darcy Umfridge, who's the author of Neuro Rehab or something like that. She just used to always say that, your patient will tell you how to treat them. You just have to listen. And I would say that's pretty right on. The more you start working with patients, they pretty much are telling you exactly what they can and can't do. And ultimately, that's what you want to be able to get them to be able to do, right? They may explain where it hurts or what makes it hurt, and then they're basically telling you what exactly they need to do to treat it. And I think that happens a lot more. I think when we're younger, we try and ask so many questions that sometimes we're trying to gather too much data, as opposed to being able to kind of simplify that data and that data gathering process. Another thing, we've talked about this before also, is that half of what you are taught in school in 10 years is going to be taught to be shown wrong, right? We just don't really know what that half is. So, the longer you've been out of school, the more cycles you're going to see of this, okay? And so it's kind of like what you're seeing with this whole COVID-19, right? You're hearing all these different things that they first thought was, oh my gosh, this is what the deal is, this is what's kind of causing this, and yada, yada, yada. And then 2 weeks later, they're like, oh, whoa, no, maybe not, right? Or, hey, this is the particular medication that shows promise, and then a couple of weeks later, oh, no, maybe not. Right. So I think that's kind of the perfect example of what we're seeing as well in the physical therapy practice world. A lot of things come and go in cycles, and things that are really sexy at the moment. Got that in there, Phil? You like that? Sexy, right? And so they end up kind of turning out to not be so great. So that's kind of why I jokingly say a lot of things you might see on Instagram, you have to kind of look at with a little bit of a grain of salt and be able to kind of determine what you're really looking at. George Davies, who's also part of the faculty with the residency program, he comes out, teaches a 2-day course with us, either on the shoulder or the knee. One of his greatest quotes is the success of, or our success is the result of good judgment. Good judgment is the result of experience, and experience is often the result of bad judgment, which basically means that you have to make mistakes in order to be able to learn and to move forward and be able to remember those mistakes to be able to do something better for the patient or the athlete that you're working with in the future. I think that's right on. So, another thing that I kind of think of is another one of my mentors is Richard Jackson out in Middleburg, Virginia. He owns like 20-something clinics out there. But he used to teach nationally on SI joint, lower kind of half functional interdependence and relationships and things like that. He used to always say that as physical therapists, we have this huge identity crisis. We don't really know what we really do. And that is going to be actually a test question for you once you kind of get going is, we've asked everybody in a staff meeting, what exactly does physical therapy do? And the reality is everyone will have a different answer. So however many people you have in the room is how many answers you're going to get. So again, this is kind of the irony of this whole thing, is last night talking with Paul Christensen, he says, you know, when I first started 40 years ago, physical therapists have been saying that people don't know what we do. And he goes, has that changed? And I'm like, no, it hasn't changed at all. So how do we expect insurance companies to reimburse more? How do we expect doctors to understand what we do and how we can benefit their patients? How do we expect the general public to know what we do if we can't even define what we do? So the challenge was, and even, you know, Paul said this yesterday and Richard has said this for years, is in one word or one sentence, what do we do as physical therapists? And I think this is probably the best thing, is that we stretch, strengthen, functionally retrain, and educate patients. It's as simple as that, right? But then you really talk to a lot of PTs and they'll start going, oh, well, we mobilize this, or we're the movement specialists, or we movement analysis and all this other crap, right? And I think bottom line is, I think we are kind of just trying to restore people's quality of life. But how do we do that? By stretching, strengthening, functionally retraining them, right? So any way you hash it, that's basically the best way to describe what we actually do, okay? And sometimes you'll hear people, oh, well, PT, you know, what's the difference between a personal trainer and all this other stuff? And that's the kind of where it's clear that people don't really know what we do, okay? So I think we need to understand that. In terms of what we really do, it's all these things, right? It's the restore range of motion, whether it's joint motion, flexibility, strength, balance, proprioceptive function, all that per the athlete's goals. We educate people a ton, and we have to communicate a lot with different professionals, that whether it's a doctor, athletic trainer, strength coach, you name it, or position coach. I think we've always got to remember those two things. Now, as I've gotten older, I think that the two main things are the two at the bottom. The better you have a relationship with those allied healthcare professionals that you have, the better your career is going to be. Two is also, I think, the better you can educate people on the level that they can understand it, the better you're going to do. So I've found that I use a lot less technical terms of getting into different things that, you know, speak at a very different PT talk, because when you speak to an MD, they may speak very differently than you. We read physical therapy journals or athletic training journals, and they read medical journals. So when we actually try and talk, they don't use the same vocabulary, although some of it is medical terminology. A psoas release to a doctor is a surgical incision to release the muscle, right? So that's where we have to be careful with what we say to what we say to a doctor. And I think we forget that all the time, but that's why communication becomes really key to who you're actually talking to. Return to play means something very different to a coach than to an athlete, right? So I think we have to be able to understand those different levels of communication. So that's kind of where we think of this whole thing of where a year of residency really starts. And that's with clinical reasoning, right? And we try and fit 5 years of experience and teaching and treating patients, everything like that, into 1 year, so you can think and reason a little bit differently than when you start. Okay, because I think you come out of PT school with all of this information about being a physical therapist, right? And you know, whether it's the anatomy courses and physiology courses, or the Therex courses and all these things that you learn, but then you get out and you're just like, well, shit, how do I put this stuff together, right? And you just your mind's going everywhere, right? So I think that's kind of where I don't think that's unusual. I think everyone comes out of school with that whole thing, and they really can't figure it out because they got too much crap going on in their head. So when we start looking at that, is we have to kind of figure out really what is that particular patient's problem that's in front of us. It has to include those decisions about how we interact with those people, what their goals are. So it's not always about what we want. It might be what they want. And also any of those barriers that might slow down, limit, or change the outcome of physical therapy also have to be factored into. But it also has to be very patient-centered. I think the more patient-centered you are, the better you're going to do, because the people, it's all about the people that you serve. If you can kind of relate to them, help them get to the goals they want to do, they'll come back and serve you with referring other people or taking care of you in other ways. A lot of those things that we kind of start looking at in terms of what you guys are seeing way more with the whole DPT education is looking at clinical practice guidelines, or the whole thing of evidence-based practice. And when I was in school, literally, it was like evidence-based practice was just, you know, pulling up like encyclopedias and referencing a book, right? And I remember first week of PT school, one of my classmates saying, the book is wrong. And, you know, 31 of us in the class turn and look at him, and, you know, with daggers flying out of our eyes, looking at him and going, how can the book be wrong, dude? If someone wrote a book, it's got to be right. Well, the reality was he was right. The book was wrong. okay, because things had changed, because the evidence had shown that that wasn't necessarily the best way to go about that particular thing that we were talking about. So it's kind of an interesting thing. Again, that's where the evidence will catch up to what we think is the best at the time, but it might change later. So when we start thinking about how that applies to the patient is, does it fit the particular patient you're working with? And is there a role for that whole empirical reasoning? Like, what are the things that factor into what we're dealing with this particular patient, or what things are in play? So you can think of patients as being really easy or really, really difficult. And the reality is, what is it that makes them really easy versus really difficult? And I kind of beg to differ. I think it's the personality of the person you're dealing with, or it's the personality of how you can communicate with that particular personality. Usually the conditions aren't that difficult. Okay. And I think Phil can use a good example on someone that he's been working with, that there's a lot of other things that factor in that make it a relatively difficult, complex patient or manifestation of symptoms. But the reality is it's not that difficult to deal with, right? So sometimes things get a little bit clouded in the heads of people. So a lot of that whole thing, evidence-based practice, is, we're looking at transparent outcomes, things like that. In our clinic, we really look at trying to find functional assessment questionnaires that are somewhat reliable and valid. I'm sure you're starting to see a little bit of that over at Bill's clinic, where we utilize over here Leishholm for knees, Oswestry for lower back, NDI for necks, shoulder FAQ, or the DASH. Rob will teach you the shoulder FAQ, which he devised on his own. We use the quick DASH for the arm, shoulder, and hand, as well as photo, which is that kind of, what do you want to call it? The online type system, which kind of grades how patients are doing compared to averages and things like that. I think that's a really, really helpful thing too, and you'll get exposed to that once you get over here. I don't believe Bill is using that over at Field of Motion. The other thing too, this is a really old article by Rothstein. I'm sure you probably already got that in the readings that Jendo gave you, but it's the concept of the hypothesis-oriented algorithm for change, or the HOAC model for guided treatment. And it's basically saying that your evaluation is, you formulate a hypothesis and then you test it with your treatment strategy, tactics, and techniques in order to determine what the outcome is. And if your hypothesis was correct, you would select the right strategy, treatment, techniques, and tactics, and you would see a positive change, right? If you had the wrong hypothesis, you may have completely been off in terms from the beginning, or it might be your techniques or tactics that are off, right? So when we start seeing our patient, they usually have three major kind of issues. One is the patient identified problems. So those are the things that they kind of know, or you'll be able to figure out before you even really see them. There's the others that really don't exist yet. Okay, so those are the problems that are likely to occur in the future based on what you're seeing, right? So those could be things like the cascade of Fairbanks changes at the knee or stuff like that after a meniscectomy, et cetera, et cetera. There's also those that exist, but the patient's not aware of them. Okay, so those are kind of the idea that there may be some impairments or physical mechanical problems that you just find during the exam. They may have lower back pain, but they also have an SI joint problem, right? So the SI joint may or may not be painful, but they do have a concomitant SI joint problem or stiffness at the hip, right? So those are things the patient may not be aware of in terms of a patient identified problem. So it's a non-patient identified problem. So in our clinical reasoning, we always include the exam, evaluation, diagnosis, prognosis, intervention, and then outcome. When we do that exam, we really want to kind of interview the patient, generate those patient-identified problems, and figure out what is that problem. Then this is going into that HOAC, is really generate a hypothesis. And then what are the complications or comorbidities that are also involved that can slow down your process, right? So it could be psychological. It could be fear. It could be different types of how they perceive things, et cetera, et cetera. It could be chemical dependencies, or it could be other comorbidities like heart disease, et cetera, et cetera. We plan that examination so we set it up to either prove or disprove our hypothesis. So we examine the patient and refine our hypothesis as we go along through the exam. So a lot of times people will say, well, what do you think it is? And you might go, I don't know yet. I'll give you an answer in a few seconds, right? It's because you're still collecting a right amount of data, but you're not just taking it all in. you're starting to see and identify clustering signs and symptoms, which allows you to come up with a better hypothesis quicker. So that evaluation is really interpreting the data from the physical exam, finding out those non-perceived patient identified problems, and developing a working diagnosis, or that's our physical therapy diagnosis, which is our hypothesis. Our hypothesis has to be kind of relating to a stage of that condition and the irritability, as well as the anatomic structures involved. And then we select our treatment intervention or approach. Got it? So that evaluation process is a school of thought that we kind of try and teach here. I think our best way, I think I kind of sent out some information from NIOMT to you guys. And so kind of looking through North American Institute of Orthopedic Manual Therapy. And I think they have a really good approach of looking at orthopedic patients, but utilizing different schools of thought. So utilizing the Norwegian Olaf Avian school of thought, which is the provocation alleviation, to say the Maitland, which is all about pain centralization, to McKenzie, which is the extension and all this other stuff. I think those all have very, very good things. Well, NIOMT really looked at all of those different schools of thought and tried to put them into what was the most effective techniques, tried to throw out the rest and teach you the best, right? That's their whole concept. We're trying to teach you something that is utilizing where you know what to pull from. You'll know when to use whatever thing you need to. I'll use the example when Dan Ramirez was a resident with us a few years ago. He came out here and he was just like voodoo band and everything, man. I mean, everything got a voodoo band wrap on it, and he would just move them and do all this shit. And it's like voodoo band, man. It's the thing that works, right? And I was like, dude, I don't care what you do, but you better have a reasoning behind it. And he's like, well, I think this is what's going on. Well, is that what's really, I don't know. Okay, well, let's see. So that was at the beginning of the year. By the end of the year, Phil, you would probably agree, that voodoo band came out like once a week, where I think before it was coming out like 15, 20 times a day. And so then by the end of the year, you're like, why don't you use as much? Well, I think I see it help much more when the joint needs some compression. It needs some fascial movement, like there's some scarring that's superficial. So it allows that compression that makes the joint feel better. And then they do some active movement, which gets the scar to move better. Okay, so do you still use it on everything else? No, not really. Interesting, right? So it's changing that thinking process, because it made him think about, what am I really doing it for? And is it really going to be, am I getting the biggest bang for my buck out of using it? And yeah, I'm sure if you do the shotgun effect, you hit everyone with it, you're going to get some success, right? But if you only use it 2 or 3 times and you get success 100% of the time, then you kind of know what you're doing there. So the idea is that we want to be able to have an eclectic approach to selecting treatments, and that results in better outcomes that are more effective and have a little bit better care. But it also is really our job is to be able to plan that treatment and determine the dosage. So it's just like a doctor. If a doctor says you need to take penicillin 250 milligrams BID, they know that that's going to be the right dosage, right? But they don't know that someone's going to do best by loading up the tissues and doing 4 sets of 6, right, 4 times a week, and then doing the opposite muscle group or a complementary muscle group, or isolating a particular muscle group on top of that for strengthening, right? They may not know how hard to aggressively mobilize that particular joint. And that's the dosage part that makes the professionalism of physical therapy the key. So we have to be able to determine that dosage. Another thing I think that's really important, and I think this is something that's come out in the last, probably 5-10 years, is really the concept of therapeutic alliance. I think this was something that, I don't know if you guys recognize this, but in some of the talks that we do, we really kind of emphasize therapeutic alliance, because it's the working rapport and it's that connection between the patient and the therapist, especially during rehab. Okay, so by definition, it's a complex interplay of technical skill, communicative competence, and a reflective capacity of the therapist to respond to the patient in the moment of therapy. So that's kind of that whole bond. So if you're able to utilize therapeutic alliance, it makes them get better as a non-specific effect, which is just like placebo. You don't even have to touch them. But if you've already established a therapeutic alliance, they will get better. Okay, that is also the theory behind having time with our patients. How many times do you hear a patient say, well, you guys are the ones that hear what's going on. The doctor doesn't even know. I only spend 5 minutes with him. this is why. Okay, so there's 5 E's to therapeutic alliance, and that's engage, empathize, educate, enlist, and end. Okay, so we have to be able to engage the patient at some level that gets them to go in. We have to empathize with their particular situation. Then we have to teach them about what's going on. Then we have to get them involved to participate, which is the enlist. And then we have to be able to end the session or particular treatment of care. If we are able to hit those 5 E's, you will have much better outcomes without even really being a very good therapist. So people that have very good skills with this are much more successful than those people that have the skills of the stretching, the mobilization, or the strengthening. Okay, so it's very, very important part of what we do. Another thing is understanding particular patients' response to different things. I've been doing this 23 years now. I have had 3 patients in 23 years say that they have a low pain threshold. 3, okay? And one of them was the toughest badass guy I've ever met, and he's one of the originators of the Ironman, the originators of the marathon, the shoes and all that kind of stuff. That's the guy. He was a football player, wrestler, you name it, and he's like 80 something years old, and he's still running half marathons. Okay, he's the only guy I've ever really heard that said I have a low pain threshold. This article I think is really, really important, because I think when you start to hear people say they have a high pain threshold, it really means they don't. Okay, so what they did was they took rotator cuff patients, they interviewed them pre-surgically, and said, hey, do you have a low pain threshold, a medium pain threshold, a high pain threshold, or an extremely high pain threshold? Everyone that said they had an extremely high pain threshold, post-operatively after having cuff surgery, took the most pain medicine and complained the most about their problems after surgery. So it was very, very clear that people that say that actually are really not that. So when you hear of 99% of your patients saying they have a high pain threshold, it means that that's why they're there. They don't have a high pain threshold. They want someone else to kind of take care of that for them. The other thing you have to remember is many patients, this is 100% true, many patients are seeking medical treatment primarily for the reassurance that their symptoms are not life-threatening, right? That's that whole push towards the DPT, where we're supposed to be able to differentially diagnose so we can screen out the medical disorders and screen in the musculoskeletal. But the reality is, just like what we're going through with COVID-19, right, is once people realize that they're going to be okay, things start changing. Behavior starts to change. So a lot of times people will be absolutely terrified when they walk in the clinic. When they're able to figure out that it was a very simple thing that was bothering them, and you can help it by teaching them 1 or 2 exercises and a stretch, they're like, the weight of the world is lifted off their shoulder. Okay, so that's human behavior, and I think these are the things that we really want to be able to understand, especially when you start to evaluate more patients, you start to see them coming into the clinic. Another big thing, and I think this is something that I learned from Eric Mira originally. Eric Mira is also another part of our faculty. He teaches ACL and hip FAI type courses and things like that with us. He's very active in the sports section. One of my good friends, and I listen to him on PT podcast. I think it's a great, or PT Inquest, which is an online journal club for physical therapists. He and JW Matheson do a great job at analyzing different articles. JW is a huge therapeutic alliance guy, and Eric is the guy who introduced me to locus of control. The second place I ran into this was Carol Quinn, the author of Motivational-Based Interviewing. And her whole thing is being able to interview people to determine what is their motivation to do something, not get something. So this is kind of like in the employee world, right? So when you're interviewing someone for a job, they may really want the offer, but they may not really want to do the job. So we have to be able to determine what their true motivation is. And one of those things that they really assess in this whole book of motivational-based interviewing is the locus of control, which is basically how that particular person perceives things that go on in their life, right? So they kind of think that there's some things they can control, there's some things that they can't. External locus of controls, people that perceive things that are everything that's outside of them. It's like the quote, that jerk punched me, right? Versus an internal locus of control is the perception that they have some of those control and can change some of the outcomes that occur to their life. Instead of saying that jerk punched me, they might say, well, I accidentally shoved him, called him a word, and then he punched me. right? So they can sit back and realize, there's two to tango here. It's not just him, right? It's the same thing in workers' comp situations where a lot of patients will say that it's their job, their boss's job to get them better, or they got hurt on the job, so the boss needs to pay for it, right? That's a very external locus of control. What we find is that patients that are kind of external locus of control tend to be people that had no control of how they got hurt, right? So that is workers' comp. They got hurt on the job, they got rear-ended, something like that. So they have these things that they'll say to you in the interview. I need you to fix me, right? They can't do it themselves. They need someone to do it for them. They also come in a little bit upset or disgruntled saying, if my doctor would have first diagnosed me correct earlier, I wouldn't be in this mess. They're blaming someone, right? My boss keeps making me do all this work, and I think that that's what's keeping me from getting better, or I just need surgery to fix it, right? They don't want to rehab it. They want to fix it, okay? Or there's no one that can figure out what's wrong. No one, right? And I've heard that many and many a times. People have seen 2, 3, 4 different therapists, 2, 3, 4 different doctors, and then you're the one that can figure out what's wrong with them. And then I start thinking I'm just that next moose head that's going to be up on the wall because they've already seen, the deer, they've already seen the elk. Now I'm the moose head, right? They're just stuffing heads and putting them up on the wall because they're just going to burn through you just like everyone else. The internal locus of control is those people that take ownership of their own problems, right? So you aren't going to hear them saying that stuff about other people. You typically think of athletes in this group, but that's not always, right? You're going to see people that are not always perfect. They may be kind of looking back and saying, oh, well, hey, my team is not taking care of me, so therefore I'm not going to trust them. In the first place, they may not necessarily be those people that easily go to get care. They take time to go to the doctor, they take time to get in there. But generally speaking, they're self-sufficient, self-motivated, and those are the quote unquote easy folks, right? They just kind of get better because they're motivated to do the work to get better. So I think that's kind of where you start to interview people. You can start to see what types of personality types you're dealing with when you're working with them. So when we start going down that whole problem list, we want to look for those problems that generate the hypothesis of why they're there. Then we list anticipated problems and generate a rationale for why they exist. And then we kind of generate a functional goal for each of them. They have to be measurable, behavioral, as well as have a time stamp to them. So what do we think the outcome will be if we choose a reassessment procedure to kind of determine the initial response? So that's the test and then treat and then retest, right? You hear that through Maitland says that kind of stuff all the time with PAs, things like that. You also want to have some sort of a long-term response to the intervention and establish a plan of care which has those specific interventions and also how you prioritize different things as you go. Your intervention of what you're doing is your strategy. Okay, so that's whether you educate them, you're going to kind of teach them about what you saw, what you found, diagnosis, treatment, their responsibility, that buy-in, the engagement, the enlisting, and then what they can do to self-manage themselves, right? The tactics are what we do in terms of stretching, strengthening, retraining, or reducing their dependence and fostering independence. So now we go ahead and start to treat, right? So we should know what we need to do once we get enough information. So when we start treating, first question you always go through, right? What do we treat first, right? I would say a couple things is always treat proximal to distal. Clear the proximal before you go distal. Second is what tact? Do you stretch them? Do you strengthen them? What do you do? How hard do you go, right? How often or how aggressively? The dosage, the frequency. And then how do you evaluate the response to that? What's the slope of the recovery? Are they getting better? Are they getting worse? Are they kind of staying the same, or are they going up and down, right? To me, positive slope's easy. Just keep them going. Just don't let them fall off the rails, right? If they're going a negative slope, why? Right? We got to figure out, are we going too aggressive? Do we just completely treating the wrong thing? If it's static, we need to make a change to that. And if it's oscillating, we're probably missing something. We're just kind of chasing pain or something like that. Our outcomes, we have to determine whether those goals are met. If they aren't met, why are they not met? Okay, if they're not met, we have to change our diagnosis or our hypothesis. Then we change our strategy, or do we change our tactics? So that goes back to that thought process of being able to go through that hypothesis. What do we need to do? Do we need to change something along those lines of what we're doing? So when we start thinking of the biomechanical approach, and I think this is kind of one of those things that it's not as simple as an FMS. It's not as simple as an SFMA system. There's all these different systems that are coming out. And I think the newer grads want a system, right? Unfortunately, systems are good for making a business run, but they're not necessarily good for a thought process, because I think people are a little bit different. People have different ways of deciphering things and being able to figure things out. But the bottom line is, when you do this, your thought process of your exam or your interview is to try and create forces out of what they say. So when they say something, it's like, well, when I sit, it hurts. So what is happening to their back when they sit? They're getting a compressive force from gravity, right? Or it hurts when I stretch it, right? So that might be a tensile intolerance, right? Or they tore their ACL, non-contact. That's a shear. They tore because they don't have anything that attenuates shear very well. So we want to selectively recreate motions and forces, and that's the objective or provocation testing. Then we make an assessment and we base our treatment with respect to the tissue tolerance to the forces and pathology they may have. This particular patient in the bottom, everyone looks at her left knee and goes, oh my God, that must be the painful one, but she was actually coming in for pain on her right knee. Okay, so long story, I could tell you guys another story about that, the sequelae of that patient, but it was kind of a cool one, because you kind of look at her and you think it's got to be that left knee, and then no, it's the other one that hurts. Okay, so you're going to end up treating what you got to go after. So in deciphering symptoms, we want to be able to translate what makes them better and worse into more motions and forces. And if the symptoms don't have a clear mechanism or mechanical behavior, then that's when we start kind of going, wait a minute, is this really something that we can treat? Okay, it might be something totally different. Could be something of a bad, neoplasm or something like that. So we got to keep that in mind. Our goal out of that is really to determine the sins. Are you familiar with this, Abdul? Like the sins, severity, irritability? Perfect. So I'm going to simplify what it means. Okay. So severity is your functional assessment questionnaires. So if you filled out an Oswestry, it's a back patient, and their numbers are completely jumping off the chart. They have 40% limitation, and they've got a 7 out of 10 pain. They have a high severity, right? So the amount of things they can do severely limits their ability to function in life, right? And Leishom's the opposite. If they got 95%, it means they're functioning very, very well with their knee. But if they're at 10 or 12, well, geez, they aren't functioning very well. So they have a high severity for a knee problem, right? The irritability is that 24-hour pain kind of cycle of how easily it is to aggravate and how easy it is to subside. What we use for irritability is essentially a 10 centimeter visual analog scale. The higher irritability patients will be farther to the right, from like 5 to 10. Lower irritability will be 5 or lower, right? So you'll know right away. You get that FAQ, you can look. Severity is what they filled out based on score of the FAQ. And then the irritability is their self kind of proclaimed visual analog scale of how irritable their symptoms are. The nature is more than just a diagnosis. It's what we're trying to treat. Okay, the stage of where they are, are they in the later stage? Are they in the early stage? Where are they in that healing process? And the treatment is clarified by the nature of the problem. The vigor of the treatment, or how aggressively you go, is clarified by the severity and the irritability. So if they're extremely high severity, high irritability, it's more of a hands-off type condition. You might not do as much intervention. You may have them just find body mechanic positions, right? If it's low irritability, you're going to exercise them. You're stretching and strengthening them, right? You're going for it. You're banging it out, right? So that's kind of how you have to kind of look at that. In terms of the physical forces, again, those main forces are compression, which stimulates bone, cartilage, things like that. Tension lengthens, stimulates ligament, capsule, muscle, and tendon growth. And shear is the combination of compression and tension, which there's no tissue in our body that attenuates shear. Hence, a shear is an ACL tear, right? So that's kind of where we start to look at those different things of what things are stimulating, what type of forces are creating what type of stresses. So forces create motions. Real simply put, is rotations occur around an instantaneous axis of rotation within 3 cardinal planes. Translations are more motions that occur along a plane and are thought to be more like sliding. So again, that's kind of where things might have what we consider a translation or an instability in the spine versus a rotation of a axis of instantaneous axis of rotation may change depending on how we may move, right? So lumbopelvic rhythm, using inclinometers, things like that. Initially, when they first come in, they may move only from their hips, but then later they move through the entire lumbar spine and their hips, which has changed the instantaneous axis of rotation, which improved their forward bending. Does that make sense? So our goal is really to translate the patient's descriptions into forces and motions. If there's no mechanical behavior, are they appropriate for PT? And then we write out a diagram, if you can, to really find out the relationship between this neck pain and does it have a relationship to the elbow? This neck pain, does it have a relationship to the numbness and tingling in their finger, right? Is it constant or intermittent? And that's usually the Maitland approach for subjective exams. A macro trauma, I don't know if this video is going to run. I believe this macro trauma was a mom throwing a ball to her son, and the son hits it and whacks her or something like that. Those have a distinct mechanism of injury. Those you're going to kind of call it pretty straightforward. Micro trauma, I don't know if this video is going to work either, but those are the things that occur over a long period of time. These are the people that really kind of say, it just started hurting over 6 weeks ago. Kind of random, start getting a little bit worse. So there's no real mechanism. It's usually a chronic or overuse type thing where we really have to look at their biomechanics and what might have caused that overload of those particular tissues. So this we would typically do with a lab where we do a subjective exam. We'd have them fill out a functional assessment questionnaire and then figure out the irritability. We'll do that when you get here, and then you'll do a little bit more of that when you work with Rob as well. So again, evaluation includes that observation, but this is kind of a Dennis Morgan. He's a chiropractor, physical therapist up in a Folsom area. Was really good about noticing skin creases, things like that. I think especially on the older patients, you'll see like at the neck, they'll have a skin crease right across their neck, which coincides with C5-6, right? Or you see that, just the way they move, there's something that just doesn't look quite right, especially here with these guys with the scapular dyskinesis. You're going to see these different winging patterns and things like that. Is it winging because it's weak? And if it's winging in a particular spot, why is it weak, or what's weak there? Does that make sense? So inferior border versus superior border migration, or medial border and things like that. So, but just giving you a cue to just kind of keep your eyes open there. The objective exam is really to selectively stress each tissue, right? So it's trying to make them hurt a little bit, right? To recreate some of their symptoms and then alleviate it. We do look at the visual inspection. The active range of motion is their willingness to move, but we're looking at 3 things. The quantity, how far do they move? That's using your goni or your inclinometer. The quality, what does it feel like, right? So when they go in a particular motion, do they feel a stretch in the opposite, or do they feel a pinch in the direction they go? And what is the effect of their symptoms? Does it make it worse? Does it make it better? What's going on there? So we always are determining QQS, quantity, quality, symptoms. Passive range motion is to determine that end feel at the very end of what a joint feels at the end range, which simply put, and this is a Canadian cheat sheet here, is essentially you look at how far do they go with shoulder elevation, right? That's your quantity, 155 degrees of elevation. The quality, what does it feel like? I get a little bit of a pinch at the top, right? Effect on the symptoms, yeah, it makes my symptoms a little worse. How do you determine the passive motion? Instead of having to recheck it and you passively ease up, cheating a quick way to do that, just push it further, over pressure, right? So that's your passive range of motion. So you can get your answers right there real quick. That's the Olaf Avian, Freddie Kaltenborn, Norwegian manual therapy. I think Olaf Avian just died too a couple of weeks ago. But those are the guys that developed this whole thing. Their whole thing was about alleviation and provocation. The testing is make it hurt, make it better. If you know how to make it hurt, you know how to make it better, right? That was their belief system of how they do that. And that's basically what we're doing in almost all of our testing, right? So again, active motion testing is looking at their willingness to move, the quantity, the quality, the effect of the symptoms, and determining that end feel. One thing that we look at, especially post-op patients or stiff patients, right? Patients that don't have good range of motion, we use Cyriax's sequence of pain and limitation with end feels. It's a traffic light analogy, okay? So if you get pain before you feel the resistance of their motion, it's a red light condition. Back off, right? I'm just going to say you're gaining someone post-operatively with shoulder motion, right? So you're trying to gain shoulder elevation. You're doing passive range of motion and they feel a pinch at the top. That's a red light. Back up, right? A yellow light or pain at the beginning of resistance might be they feel a little bit of pain at the top and a little bit of stretching on the bottom. So you just got to be careful, right? You don't want to go too hard into the end range. If they get pain after the resistance, so they don't really have a pinch at the top, but they feel a nice stretch in the lat and the pec, green light, go after it, right? Then you can keep pushing through that. So you start using these green light, yellow light, red lights instead of the capsular end feel or the empty end feel or all these names they used to call them. It's just like, what are you seeing? They got a red light end feel. It just hurts. Okay, back up. Don't take them to the end range. Well, they get a little bit of pain at the top, but they also get a stretch. Yellow light, be careful. Work your way through it, right? It's just like going through a traffic light. If they have no problems, stretch it, go after it. You can start to strengthen too. That's going to be a green line. Okay, so you can see it. George Davies always said when you're gaining range of motion on shoulder, best way to tell if you're pushing them too hard, look at their eyes. If their eyes start bulging out of their head, you're probably pushing them too far. If they aren't, pretty good. Best analogy I've ever heard of this, I was working with Paul Starks, a therapist who was working with a shoulder patient gaining range of motion, and every time they took them through range, the patient was like, "Ah, ah, ah," right? And Paul's like, kind of like, and he's thinking to himself, I'm only a PT assistant and athletic trainer. I probably shouldn't say anything to this therapist because they're a DPT and they know more, right? So he comes over into my office, he sits down, he looks at me and goes, just wanted to kind of run this by you, but I saw a heck of a lot of orange lights out in that gym there. And so I knew exactly what he meant, right? This person's jumping off the table and screaming, and the therapist just doesn't pick up on the enfields. They're just blasting through the yellow and the red. So it's like, that's where you start to feel, you start to see, you're using multiple senses to figure out what that end range is. So contractile lesions, again, those muscle tendon, myotendinous junction, tendon periosteal junctions are painful with active range of motion and resisted motion in the same direction with passive range of motion in the opposite, which basically means contraction, resisted contraction, or a stretch. That's a contractile lesion, right? So that's usually a cuff tendonitis that you see. You contract the cuff and it hurts. You take it off, they're fine, right? Non-contractile lesions is painful with active range motion and passive range in the same direction, but there's no pain with isometric testing. It doesn't hurt them at all, right? So that's how you can differentiate whether it's contractile versus non-contractile or more inert tissues. Isometric testing, we use the little thing in the middle there, the handheld dynamometer, to really look at C-reactive selective tissue testing. If it's you can kind of think of all these different combinations you can have. Ideally, you want to have the top two, pain-free and strong, right? No muscle lesion, no muscle tendinous problem there. If it's pain-free and weak, you might have a tear, right? If it's painful and strong, you might have a tendinopathy or you might have a partial tear or something like that. But there's a couple things that you want to look at. So you grade it based on normal is strong, pain-free and strong. A grade 1 lesion, contractile lesion, would be painful and strong. A grade 2 would be painful and weak, but the false positive for a grade 2 contractile lesion is a fracture. Okay, so I think a couple weeks ago we talked about little league shoulders. Okay, guess what? Little league shoulders is a fracture at the apophyseal plate at the proximal humerus. So when you test those kids, they have a recreation of pain to external rotation at their shoulder, and then they hold their arm like this. Does that mean this kid has potentially a grade 2 cuff lesion? Probably not. Because of their age, it's probably a growth plate fracture. You can pick it up right there, right then and there. So we talked about that a couple weeks ago with that other talk. The other thing that you start looking at, and this is especially as you get into the older population, is a grade 3 muscle tendon lesion would be pain-free and weak, which basically means it ain't there, right? So they tore the muscle or they tore the tendon. The false positive to that would be a neurological weakness because it's usually fatigable and pain-free. Okay. So whenever you see those like grade 2 or grade 3, you always got to remember the false positives and recheck, maybe test it in a different position or things like that. Okay. So this is where it gives you a really good thought process when you start doing your muscle testing. Okay. Other special tests, other flexibility tests and measures, we'll go through all those when we start getting in a little bit more in terms of flexibility using inclinometers, girth measurements, stress, ligament stress testing. The scan exams, neurological scan exams, those are going to be big time. We're going to test you. We're going to time you. We're going to make sure you're doing these things right. So those are the things that we really kind of emphasize. You ever see the movie Top Gun? No? You guys are way too young. The sequel's coming out with Tom Cruise. He's like kind of always he's this hotshot naval aviator, and it's all classic Tom Cruise movie, right? He always starts out on top of the world, bigger and badder than life, gets all the chicks, and then he goes through some big bad ugly, personal thing, and he's down in the dumps, and then he somehow comes back and rises out like the phoenix, and he's bigger than life again. Same thing, Tom Cruise movie. So his whole thing is his flight instructors say never leave your wingman. Well, one of the things you're going to hear throughout your year here, Rob Neighbor is going to say the same thing, your neurological scan exam, which is dermatomes, myotomes, reflex testing, dural testing, et cetera, is your wing. Whenever something doesn't seem right with an orthopedic problem, there's usually a neurological deficit underneath it. So you pretty much never leave your wingman. Every time you don't do that or you forget about it, go back and retest it. You'll probably find something. And then that's going to change your course of treatment. Because if someone has shoulder pain due to a radiculopathy and you strengthen them, what's going to happen to their strength? Remember, grade 3 lesion. It's going to fatigue and not get stronger, right? It's going to seem weak. It's going to seem like a tear. Versus the treatment for a cervical spine radiculopathy might be unload it, some traction, right? Soft tissue, loosen them up, stabilize it, get the neurological deficit better, then strengthen their postural muscles and their scap or whatever you need to do. Totally different treatment technique, right? Again, but treat the proximal before you go to the distal. So the way we have it set up is an upper quadrant exam and a lower quadrant exam, as well as a cranial. You'll get some of the cranial stuff with Liana when concussion stuff starts coming around. So neurological testing, we usually do this as kind of a lab using the reflex hammers, using the muscle testers, et cetera, et cetera. Then when we get to our assessment, we need to figure out, do we need more information? Okay. And a lot of times with just the interview and a couple quick neuroscan and a couple tests, you'll already have the information you need to know. So then you'll start going back. Assess your sins. That's your assessment, right? But we do it in 3 levels: minimal, mod, or max, right? Irritability, min, mod, max. So if they have a severity high oswestry, they've probably got a mod to max severity. Irritability, 7 out of 10, mod to max irritability. Nature could be a compressive overload. And if they have a neurological deficit, is it a conduction problem or is it a mobility problem? Right? So a conduction problem would be probably more like a radiculopathy that's kind of a disc herniation or something like that. Mobility might be they just don't have the neural tension, or they have too much neural tension, or they don't have the flexibility to get there. And then second, is it a contractile lesion or a non-contractile lesion, right? So we've got to be able to assess those different things. If it's non-contractile, we got to figure out, is the joint in what they call a capsular pattern? Well, as back in the day, shoulder capsulitis was external rotation was limited greater than abduction, greater than internal rotation. I don't know if that's necessarily the cause anymore. I think we start seeing every motion is limited in a capsular pattern with the shoulder. With the knee, it's more flexion more than extension. With the hip, it's flexion, abduction, then internal rotation. In the spine, it's side bend, rotation, and extension, which is usually a facet joint restriction. Okay, Cyriacs designed this or defined it as a capsular stiffness where the entire joint becomes tight. If it isn't a capsular pattern, we start thinking of arthrokinematic motions. If it's a restricted motion, then we start looking back at translation. Okay, if it's a translation problem, they probably have an instability. So if they have an instability, what do we do to treat it? Mute.
Stabilize.
How do we stabilize?
Strengthen the muscles around it.
You got it, right? I mean, that's all of a sudden you just went down a different path, right? But if you're sitting here going, well, I'm not sure, it could be this, it could be that, I don't know, but you already have started to think through it, right? That's exactly what we're looking for. If it's contractile, what grade, right? If it's test 2, like I said, anything that could be a false positive, you want to retest in another position or you recheck the neuro, okay? When we do our assessment, there's also, if you look in our clinic controller roll-ups, there's also these things that has mechanical versus chemical. We always have to add it up to 100%. Mechanical problems, which is most of what we see, is going to be those symptoms that kind of subside quickly. So if they bend forward, they go, yeah, that hurts my back. They get back up and it's gone. That's a mechanical back problem, right? If they go forward and they go, oh, that hurts, they get up and they stand there and they go, yeah, now it really hurts down my leg. That's more of a chemical problem. The symptoms linger after they do their particular exercise. Those people react better to positioning, body mechanics, taping, medication modalities, things like that. The other mechanical stuff, stretch, strength, and train, right? So you already know, hey, this is where I got to go with this person. This is where I got to go with this person. Pretty straightforward there. I think the other thing with chemical problems, that lingering once the exercise is stopped. I've got a Major League Baseball player right now who had a discectomy. And for the first 6 weeks or 8 weeks after his surgery, he was doing all the stuff with his training staff and his PT and his team. And he said every time he would do stuff afterwards, at night, he wouldn't be able to sleep because his leg was on fire, right? And in theory, he had surgery to remove the disc herniation to alleviate the nerve pain. So why was he having so much pain later that night? Do a nerve exam or nerve test, neuroscan, didn't have a reflex of his peroneals, didn't have any strength of his everters, weakness of his EHL, and a positive straight leg is at 40. So by trying to strengthen him, he was overloading and pissing off the nerve. We backed off, put him in positions that made him more comfortable, tried to unload the nerve, and all of a sudden he's like, wow, that doesn't hurt anymore. You got it. But then you got to teach him how to control it. So that's where the chemical symptoms will linger afterwards, or they will rear their ugly heads after. When I do an exam, if I do all of the stuff under the sun, every single special test, everything like that, and then they come in at their second visit, I go, how are you after the eval? Fine. Probably a mechanical problem, right? If they come in, you do all your exam, you do all the stuff, maybe not even all of it, but then they come in the next visit and they go, man, I don't know what you did to me in the first visit, but I was jacked up for 2 days. Probably higher chemical. Okay, so that's where you can start to see the second visit's huge, because then you can assess, did you overdo too much stuff in your exam? Because that can set them back a little bit, right? Or if you did everything in your exam and they're perfectly fine, hey man, we could start going after it. We can be more aggressive. Okay, so George Davies and Jim Gould back in 1985 in one of the original textbooks for orthopedic and sports PT put out these phases of rehab. And I think this is something that you'll start to really think about as you start working more with patients and athletes especially, is the first phase is tissue protection, maximal tissue protection. That's when people are in slings, that's when they're icing, that's when they have to be real careful about how they move, that's when they're non-weight bearing after surgery, et cetera, et cetera. Moderate tissue protection, they may still have a brace or sling, but it's more for comfort to protect them when they're in a crowd, et cetera, but they might start beginning some range of motion or some strength. Minimal tissue protection, or the third phase, is when they don't need any support. Now you're teaching them how to control their symptoms or change it to make it better, and they can start to do some more exercise. Phase 4 is they're just training, they're working out. Phase 5 is these people, if they come in as phase 5, you really don't do a whole lot for them. You just kind of consult with them, right? You're helping them, oh yeah, I'd do this or try that or da-da-da-da. But that's when you have to make the decision, are they ready to go back and play, right? So if we say, what phase are they in? We would hope that our residents or our therapists would be able to kind of spit back at us really quick. Well, they're kind of vacillating between 1 and 2. Okay, got it. So we know exactly where they are. Oh, they're in phase 3, 4. Okay, let's train them. Got it. Can patients go back from a phase 3 or 4 to a 1? Absolutely. They could fall through a wall, right? They could slip. They could do something, you name it. Something can happen. They can vacillate between phases. But this is a really good kind of thought process to understand the different phases. Again, we figure out the problems and the goals, look at them as they're measurable, timely, and then functional outcomes. Our plan of treatment is we establish a problem statement, set the goals, that they ought to have measures to them, like something that says they'll improve by X amount of percentage points in 6 weeks. What's the hypothesis or the nature of the problem? What's the tactic, strategy? What are we going to do? Stretch, strengthen, and mobilize. What are the treatment techniques, the grade of the mobilization, the duration of stretching, the dose, and the mode of exercise? So do we load them more? Are we underloading them? Or do we need to unload them? Do we need to do more? That's the treatment technique, right? So when you start breaking that down, the hypothesis is what do we think's wrong? The tactics strategy is what are we going to do? Stretch, strengthen, mobilize. The technique is how much, how hard. Do we go at it? Do we go grade 4, grade 5, or do we just oscillate grade 1? Do we stretch them? Do we do a contract relax? Do we have them do 3 sets of 10 unloaded at 50% body weight? Or do we do 3 sets of 10 with 155 pounds on their back, right? That's the technique. That's our thought process to be able to determine what we need to do. Treatment planning is, again, based on the evaluation, understanding the phase where they are. That's the severity, irritability, type of tissue injury or the injury of the nature, respect tissue healing, and whether they're surgical or non-surgical. Reevaluate them. Best to do whenever they go back to the doctor, usually 4 to 6 weeks. Short-term goals, if they are met, we keep going, right? If the short-term goals are not met, or I'm sorry, short or long-term goals are not met, we have to go back and think again. Was our treatment applied correctly? Was our techniques correct? Or was our tactic correct? Or move the further back, was our hypothesis correct, right? If we can't figure it out, that's when you bring in another therapist, have them co-treat or have someone else take a look so maybe they can give you a little bit of redirection and things like that, okay? Communication is key, especially if there's no or slow progress, but whatever you do, do what's best for the patient. A doctor never wants to have a patient walk in with a surprise, period. It's 100%. If you give them a heads up, hey, this person ain't doing well, they'll be like, well, what do you think's going on? And you give them some suggestions, they'll be, that's great, thank you. So then they go in to see the patient, they know what's coming at them. Okay, soft tissue healing. This is all based on the Wu Buckhalter studies way back in the 80s. The first phase, inflammatory. Second is reparative. Phase 3 is remodeling. Every tissue in the body has different phases of how they heal, right? So we kind of look at this as the optimal loading zone. Arnheim, the old athletic training book, was really the specific adaptation to opposed demands. It's very similar for tissue. I didn't reference in here is that the optimal loading zone, or kind of that happy little area right here in the black, is essentially this stress strain curve was devised by a doctor up at UC San Francisco named Scott Dye. He's also famous for scoping his own knee without any anesthesia, but this is another thing that he kind of coined the term of the envelope of function. So if you treat a patellofemoral joint problem with the appropriate amount of load, they will flourish. If you overstress the joint, it will result in injury. If you understress them, they will weaken. Okay, that can be applied to every tissue in your body. And that is the thought process that we want you to think about, is our job is to put people in the optimal loading zone, to keep them from overloading, keep them from underloading, which is not easy. So that's why things that, the more I started thinking about it, something like an Alter G fits. It makes total sense. You can play with that all day for lower extremity problems. So in terms of tissue healing, the inflammatory phase, eliminate that whole physical insult. It's kind of that whole initial part. The reparative is more the replacement of damaged cells with new stuff. Remodeling is the maturation of new cells to kind of get them back into. That matches best with the phases 2 through 4 or 2 through 5. Tendon healing, we don't have to necessarily go through this all really quick. We'll kind of buzz through this because we're running into time issues here. But just think of this as inflammatory is 3 days, and I have a graph for you that you'll have. It'll all be listed out for you. Reparative is really day 5, but really day 28 is collagen replacement is complete. When you see a cuff repair, typically how long do they want passive range of motion for? 3 to 6 weeks. 4 weeks. So that's the reparative phase. They want to get them out of the inflammatory into the reparative before you start going for the range of motion. The remodeling phase takes 122 days. That's a crap ton. That's 4 or 5 months, right? It's a long time. So that's what we kind of start seeing. That's when we really start to kind of be able to push that strength and things like that, the tension through there. So our job, again, is match the forces of rehabilitation of the tolerance of the tendon for the optimal environment of healing. Typically stretching a muscle tendon complex will reveal a yellow light condition, and motion should be not taken beyond that initial barrier. The remodeling phase requires active range of motion versus gravity and progressive strengthening of the muscle and tendon unit, right? So again, myotendinous junction, we'll kind of go through this really, really quickly, but again, this is a little bit shorter, 4 days. Reparative phase for the muscles, myotendinous junction is 7 days. And the remodeling, we're not sure, but the bottom line is you need to restore the tensile loads to it. Okay, so what I find is myotendinous junction or even mid-belly muscle tendon tears is you don't stretch them. You want them to scar. And then you start to kind of loosen them up, and then you strengthen it with isometrics. Then you start going through isotonics. Then you go to eccentrics, and then maybe you start to stretch it at the very, very end. But you may not never need to stretch a muscle tear. So that's one of those things you start kind of looking at. But they do really good with soft tissue, and then isometrics, and then start going from there. So again, rehab looks at first 3 days is the anti-inflammatory measures, looking there. Reparative is kind of submaximal concentrics and then minimize the excessive scarring. Stretching is really avoided because it reproduces their pain at the myotendinous junction. Progression of muscle strengthening is really not concluded, but the end is you need the eccentric muscle contraction. So that's that progression again. So I tend to evaluate whether or not I need to stretch them or not. Sometimes you don't. So. Okay, same thing with the muscle healing. This is kind of where we're going here. Tensile loads, contusion, ischemia, lacerations, inflammatory phase hours by day 7, start to see phagocytes flowing in there. Reparatives day 13, and then really 21st day is really when you start to see that remodeling, so then you can start putting a little bit more tension to that muscle. Again, rehab, progressive tensile forces without pain provocation should be applied around that 18th day. Remodeling phase characteristic by isometric changing between grade 1 and 2, increase the mechanical percentage of their symptoms, and then the progression of strengthening is concluding with eccentrics again. That's the final stages. Ligaments injured with excessive tensile loading, inflammatory phase first few days, reparatives day 3 through 14, remodeling goes even up to the 12th month. So this is one of those things that even though we're looking at MCLs that heal, like people are back playing in 11 to 12 days, a lot of the NFL studies that show that they're really quick in the grade 1s, we find they still are getting better for 6 months. You know, so we're really kind of got to just keep that in mind. Even though they feel good, the tendon may, or the ligament may not still be fully healed. Articular cartilage, these guys, they kind of suck. I mean, so the best things you're going to be seeing out there today is going to be more the Macy procedures or the, you know, the Oates procedures, things like that, osteochondral type defects, things like that. So basically, you know, it's going to be where it kind of damages the subchondral bone bleeding. It's usually accompanied with a bone bruise on MRI. You know, you're going to see a reparative phase through days 1 through 70, but the remodeling phase is 180 days. That's about 6 months. So it's not unusual to see these types of like microfractures, things like that, at about 6 months have kind of a change. But up to then, there's still some variability in how they do. In terms of our clinical reasoning form, this is that PDF that I believe Jendo sent you. It has the pull down screen, so it goes through. So now you understand what the PIP was, right? The non-PIPs, the other things, spherity, irritability, and it has all the referencing to them. This is, I would highly recommend start doing this with your celebrated first patient that you had over at Fields of Motion. Go through it with them, okay? So after you've done your eval, fill this in with all their patient information, and then you'll see what's going on and what you may need to get more information and what you may not. But you should be able to kind of determine what course of treatment you're going to be taking them and then really think it through. So it really asks you to go back and think about everything you do. So what we like to do is for the first 2-3 months, every patient you see, you're doing this clinical reasoning form. And it's backed up. We look at it. We can kind of go through it together. Sound good? Here's just a quick little case study. 40-year-old man with an avulsion fracture of his hamstring at his ischial tuberosities, 1 week status post of hamstring repair. Is this a macro or a micro trauma? What phase is he in? And is it a contractile or a non-contractile lesion? Who wants to raise their hand?
Oh, macro trauma?
Yep.
Probably phase 1.
Yep.
And it's a contractile.
Yep. So check this apparatus out, right? So it's a hip brace down to the knee, and he's at 90 degrees, and he's strapped with an ankle brace to his butt. So the idea is the hamstring's a 2-joint muscle, right? So it's going to lengthen with hip flexion, knee extension. So we keep them in neutral, hip, 0, and knee flex at 90, strap him, and then gradually over the first 6 weeks, bring the foot down about 10 to 15 degrees from 90 all the way down to the floor, right? So that's the rehab for these guys. So ironically, this was one of the things that Dillingham and I started messing around with. We started figuring out these are not easy to repair. And then second is these people are completely screwed because they're stuck in these braces for at least 4 weeks. So it's really hard to get around. You can't sit, you can't lay down, you can't really go to the bathroom, stuff like that. So kind of a cool one. So, but you're absolutely right. There you go. Avulsions of the ischial tuberosity usually occur from a fall in the splits, water skiing, with the leg and hip flexion, knee extension, the trunk flexed. So they usually will say their chest hit their thigh when they do it. Got it? So phase 1, maximal tissue protection, braces to limit the stress on the repair, and then it's a contractile lesion. Bam. Here we go. 22-year-old male basketball player with intermittent mild anterior medial knee pain. Fills out a Lysholm, a 94, visual analog scale of a 0.3 out of 10, proximal hip strength, all equal to each other's side, but his MRI does, he has a medial femoral condyle bone bruise and negative special tests. So, what's his severity?
He's low severity.
Abdul?
Mild.
Oh my.
Yep. Mild. Irritability.
I would have to look at that that test again, but irritability, if he's able to do all this stuff, I would say pretty low too.
You got it. This is your indicator right here. Because you haven't even seen the kid yet, right? He just finished his paperwork. But you already got this. You already know very low because he's got the 3.3 out of 10. Nature.
Sounds like it's the bone that's causing the issue. If it's a intermittent mild pain with I would guess activity. So, and there's no like torn ligaments from the special tests and things like that.
So it's like a compressive overload, right? So that compressive overload could be patellofemoral or it could be medial femoral condyle, right? So you got to just change his load, but he's already doing really well. So you're going to be able to push this guy hard. So phase of rehab.
I would say 5.
Probably 4, 3, 4.
5, 4.
Late
4.
3, or, yeah, 4. 5 would
Okay.
be you're just going to let him go. You're going to let him.
Oh, got you.
Yeah,
Okay.
hit the ground running and take off. So cool. There you go. Okay, 4, 5. My bad. There you go. Cool. So minimal 90 to 100 is valid, reliable for an excellent outcome. Knee rehab, minimal 0.3 out of 10, low pain scale, resolving quickly after stressor load is applied. Medial compartment overload, later phase rehab. So pretty cool, eh? Well, that's all I got for now. That's an old picture. That's not Buddy. That's Kirby.
Oh.
So cool. All right. Questions?
Oh, Kirby.
I know. Kirby. Well, good little dog. So Abdul, does that kind of make sense now that I know Jendo gave you a whole mess of like paperwork and stuff like that. So now once you kind of hear that, does it kind of start ringing some bells as to like,
Yeah, definitely. I think now I have a little bit more direction of how to kind of go through it, and especially now that I've actually seen my own patients instead of just kind of helping out with other patients. I think it's going to be a little bit easier to kind of, because it's one thing to read it and then one thing to actually see it in practice. So I think it's going to be easier to kind of go through that. I'm going to go through all those papers one more time, and
perfect.
I'll definitely print out that other one and fill it out tomorrow morning before I see my patient, and just kind of get an idea.
Yeah, just pull out your eval and then just fill it all in with all the information you collected from your eval, and then start going through the whole thing and just get an idea of what did it match what you were thinking. And then once you start treating them for a little while, is your hypothesis correct, right? So then you know if you're on that positive slope, right? If it starts vacillating, try and figure out why, right? So
Right.
I think this stuff works just as well even in athletic training. I think the main difference that you see with athletic training is there's two things. Is more often than not the injuries are going to be macro traumas, like on the sideline. And then second, you have to be kind of a little bit more level-headed because there's so many other things going on around you, right? In order to be able to kind of get to the athlete, do a quick little scan, start your subjective, and then you may not have time to go through the active passive range of motion, looking at all this other stuff. You just know, hey, something looked funny with the way they planned it. I'm just going to go after the ACL. And then sure enough, it's a positive Lockman's. You're like, okay, we're good. Let's get you up and get you off the field, right? So there's those things but the thought process is still there. I just find that with athletic training, it's a little faster. Like you don't have the luxury of having a patient fill out paperwork and give you their history with all their medications they're taking and their op report and all this other stuff. You just don't have that. You're on the fly. I mean, it's now or never, right? But then also I think the part that I find with the on-field exams is it gives you more practice to see different things, but it also allows you to make some more mistakes, right? So initially there might be like, yeah, I don't think he tore his ACL, but I think he just got his MCL, right? And then the kid goes off, gets their MRI, and it's like, nope, they tore their ACL too. It's like, huh, weird, I didn't get it, right? And then you start thinking, well, why didn't I get it? Well, maybe the technique was a little bit off with the Lockmans, or maybe it was a little bit too delayed, so that kid's hamstrings guarded a little bit too much. So then you weren't going to get a positive test, right? Or you just couldn't do it right. I mean, and I've seen that where it's hard. It's just sometimes you just can't quite get the huge leg or something. There's just something that doesn't quite work. But I think that's kind of why that whole clinical reasoning and being able to see something, and then if you miss it, you can remember that and then go back, and then the next time you ain't gonna miss it. I think a good example too is you start to hear things, and those hearing, that's that clustering of signs and symptoms that starts to recognize something. I'll use the example of at my son's high school. There was a kid who it was at the jamboree at Willow Glen. He was rushing the passer, went down kind of in a heap, grabbed his knee. Trainer checked it, looked at it, said, yeah, I think you may have like a little meniscal tear, might have like an LCL tear and all this other stuff. Kid went home, went to his primary care doc. They said, yeah, you just sprained your knee, go to physical therapy. So they went to PT for 6 weeks, rehabbed okay, started coming back out to practice, started working with the trainer, and every time he would cut, his knee would buckle and would go down in a heap, and his knee would start to swell, and he'd have to kind of rub it out and ice it, and then he'd be okay a day or two later. So the trainer calls me and goes, I don't know what's going on with this kid. The therapist said he's good to go. The doctor said he just had a little sprain. I thought he had an LCL tear, but he's still not quite right. I can't quite get him ready to go back out and play. He's still struggling. So can you come between the JV and the varsity game, just come down the sideline and check this kid's knee? I'm like, yeah, sure. So I go down there and I'm like, boom, positive Lockman's right off the bat. And I was like, ooh, shit, And so I'm like, okay, so I'm talking to the trainer. I'm like, still got some laxity, with his anterior joint, his Lockman's. They're like, really? Like, yeah. And they're like, well, can you show me again? So I show them. They're like, whoa, how'd you do that? And I'm like, let's go through it. And so we went through it a couple times. As the kid's sitting there, obviously it's a really smart kid. He goes, what'd you say? That was a Lockman test? And he looks it up on his phone and he goes, you think I tore my ACL? And I'm like, oh, dude. Well, we're suspicious that you might have sprained it, but we'll have to kind of confirm that with an orthopedic surgeon and maybe even an MR or something like that. He's like, okay, but wow, how come, it's been 8 weeks and no one's figured that out? You're like, I don't know. But that's one of those that sometimes you can't quite get it when you're on the field. And then the primary care doctor may not have the experience of doing a Lockman's or ordering a musculoskeletal exam or understanding the mechanism. And then a therapist is just following a script of knee pain or sprained knee, and they may not do an exam, right? So again, it comes back to that whole thing. If you're on the field, you see something that don't look right, and you get to test it right away, then you get to see how they're managed, who they go to see. Do they see someone who specializes in that particular problem? Are they going to send them with the right reports? And if you do a thorough eval, you'll know what to do and where to refer them or what to do next. If you never get that information, or you're missing some of that, you're lost. You're dead in the water already. So I think that's kind of why the eval still is key. And I think that's the most important thing that I would pass on to the athletic trainers is, yeah, you don't have the time to do that stuff, but it's still the better the sound or thinking process that you go through in a quick level, the better off that kid's going to be managed on the field. So, so it's pretty cool. Good stuff. Any other stuff? Questions?
I have a comment.
Sure.
I don't know if people are podcast people. I am previously not, but I started listening to more podcasts on my drives. And Eric Miera and JW Matheson have a podcast called PT Inquest.
Mm-hmm.
And they actually just recently did a segment on the envelope of function and all of Scott Dye's like articles. And it's basically everything Ross was saying, but just like breaking down the articles a little bit more and breaking down just like tissue tension theory and all that stuff. So if you're interested in just like learning more or just hearing it again and again, I think repetition really helps me personally. So just hearing it from a different perspective and for another time, just it just helped a lot. So I think
And they're super nerdy on the PT podcast. It's awesome.
they
Yes,
are. Yeah.
They are.
They're pretty
So
fun. So
it's was this one of the most recent ones, Jendo?
yeah, it was like I was looking it up right now. I just listened to it. It was in
Okay.
March.
Yeah. I think I remember that one.
Yeah.
So yeah, I would say
Yeah.
PT Inquest is really, really good. I think the funny thing about what they do is they do kill about 15 minutes of just BS. Like they'll just kind of banter with each other, and
Yeah.
it's just they're old friends. They go back a long time. They just talk a lot of smack. So, but the articles, the content that they're really looking for is phenomenal, and the way they break it down is really easy to understand. Sometimes they get really technical on things, but I think when it comes to application to clinical practice, it's really, really helpful. And so, especially if you get a chance to read the article and then you get to hear them talk about it later, and then talk about it with another group, it's definitely helpful. So cool. Thanks, Jendo.
Yeah, no problem.
Yeah, I would, and they are long, so they're at least an hour, right? I think most of them are an hour.
Yeah. But I mean, like Ross said, the first like 15 minutes was just them talking about random shit, and then
Yeah.
then they start breaking it down, and then at the end they talk about more random shit. So really, the bulk of the content is probably like 30-45 minutes.
Yeah.
So what'd you have for lunch
listening
today?
to.
Was it a
It's worth listening
BLT?
to.
Was the
Yeah.
bacon delicious?
Exactly. Yeah.
Honestly,
Yeah.
the one I listened to right now, the first like 5 minutes was Eric Miera talking about like, why do they call it a double V, a W, a double V? Like, really? It's like, or double U.
Yeah.
It's like, it should be a double V. And they're just like debating
true.
about that for like 5 minutes. It is true, but it's just like, okay. So, yeah.
Good stuff. Yeah, I think they're really good. I think they do a really good job. I think Mike Reynolds, the other one who does a really good job in small snippets, like their 15-minute podcast type.
Yeah, his are
subject
shorter.
matter. Yeah. So and his are more like just ask the guy, and then he'll do some kind of referencing. But I mean, these guys really go deep into these articles and stuff. So and then you'll get a chance to meet pretty much all those dudes at either TCC or CSM next year. So good bunch of dudes. So cool. Anything else, Phil?
What shall we talk about next week? Should we try to apply more of the clinical reasoning for next week, or
I think
what we
you
do
should.
too is
Don't you have all like special tests?
well, yeah, that one's gonna be so next Thursday will be more of just special tests and just going over those articles, and then what we could do for this one for the Tuesday after that Thursday. I mean, I was thinking, what if we talked about one of those articles that Eric Mira talked about in his podcast, or we can. I mean, I don't know what you guys have in mind.
I'm all for it. Okay, Neo.
Sorry, it froze. I was like, wait. So, okay, so
I love it.
yes, Eric Mira,
I'll just
or
mess
a
with
journal
it.
article.
Make the call, man. You guys pick it.
All right. let's go over the Eric Mira podcast and let's kind of hash it out on our own. I think that it's just
Perfect.
applicable to what Ross has talked about. But yeah, let's see. Today is the 12th, so that means in 2 weeks, the 26th. 5 o'clock works for everyone. I feel like 5 o'clock may be a good time. Does that work for everyone else?
26th. Yeah, 5:30 is better if I can run home.
5:30?
Yeah, so that should work. The 26th should work. That's after Memorial Day, you guys. Just a heads up. So that works.
I just have to be muted and no video because I'm running around the house with my knuckleheads.
That's fine.
Are
Totally
we doing
fine.
the same time?
5:30 instead of 5.
Okay.
5:15, 5:30, whatever.
How about I'll open up the room at 5:15 and then we can start right at 5:30 so everyone can trickle in.
Perfect.
We can do our
Okay.
BSing for the 15 minutes and set the scene, set the tone, and then go.
So the other thing too that Phil, what I'm thinking about is because we're recording some of this stuff, I think we can probably archive some of it into a reference library of videos and things like that for the residents that come through, and then they can go back and reference them later too. So
yeah,
cool.
Yep, I have them all recorded, and then and I'm still uploading them to YouTube too. So we'll
Perfect.
we'll have them all set for reference.
Awesome. Good stuff, man.
Well, thanks for coming to Think Before We Drink, and then we'll see you guys on May 26th.
All right, Neo. Time to go get a beer.
Thank you, guys.
All right,
Later. Bye, guys.
Bye.
Bye.